36. I can't have C.
She had a stroke.
Yeah.
There is 2 of you right now.
CVA.
There is, and
Oh, it is.
Right side neglect.
and my balance is just terrible.
Hello from the other side.
And I get so tired.
Amen.
I get so tired.
There it is.
Oh, she can't have C. Oh, gotcha.
Oh, of course,
There are
vision's
so
big.
many, and it usually starts with neuritis, but there can be any or a combination of eye problems. And that's something that a lot of people forget when they treat a patient with MS, is that whole eye thing, because that can really affect. So you can put, just for the purposes of the treatment, you can put a patch over one eye if they're seeing double, or, and that's going to be so much easier for them. So trying to figure out how it is that they see and asking them. And they really like you to ask them. Okay, so look across the room and tell me what you see. And that will help you so much in treating them. Because you can figure out what it is that they're seeing, and that can help you address balance and that kind of thing. With the patient with MS, it's the same thing as like a patient with a head injury. You don't know what you got till you get in there, because it depends on where those plaques are in their brain, in their spinal cord. They can even have plaques coming out of the spinal cord with those nerves, which gives them more of a peripheral type thing. So they're higher motor neuron yet, usually, but there can be some lower motor neuron problems as well. The spasticity typically doesn't go away with a remission. Most, 85%, are going to be patients that end up getting better, and then getting worse, and then getting better. And they can end up getting better than they were 2 times ago with their exacerbations. So it's very unpredictable. The thing is, that makes it very difficult on the patient, because they get to the point where they're counting on feeling so much better, and then something else happens. So it is a very devastating disease in that way. The spasticity, though, typically does not go away. The spasticity stays the same. So with different exacerbations, the spasticity can actually get worse, but typically that's not going to be affected. The eye problems can come and go. They can end up with different eye problems. They can end up with a combination of eye problems. More often than not, the lower extremities, for whatever reason, tend to be more affected than the upper extremities. And very, very often there are those plaques in the cerebellar portion. So very often a patient with MS is going to have some problems with balance and coordination. And in fact, we'll run through this on Monday, but there are these exercises called Frenkel's exercises that are coordination type exercises that you can do with MS patients.
As far as the presentation and how each patient is going to be different, how thorough are the PTs able to be in their initial evaluation? As far like, are we going to see the presentation on the notes, what to expect, or is a lot of it just going to come from our treatment?
No.
To find out what they're lacking?
Very often with the neuro patient, you think in terms of the best thing would be like an hour to an hour and a half for initial evaluation. There isn't the time
They
to
don't
do
get that, no.
So you're going to be picking up on a lot of things that they may be, and I'm not saying they're wrong or that's bad, or.
But you will see a
you're gonna
lot
be
that's
seeing
not
them
included.
More, and so you're going to pick up on things that they did not pick up on. Definitely.
Since we orient towards progression, and these patients have exacerbations, how do we note that in the SOAP note? Would we just say patients experience exacerbated symptoms? Therefore, progression's not an option at this point. How would that work as far as?
Typically, they're going to have an exacerbation, and you're going to be working with them, and you're going to be working with them medium. You're not going to be doing too much, but you're not going to be doing too little either. You're going to be working with them at a moderate pace, and you're going to have a day in between treatment. You're going to make progress with them. It's not like they have an exacerbation and then nothing happens until they're in remission. They have an exacerbation, and you're going to be making improvements with your patient, and then those signs and symptoms at some point will kind of subside. But you don't know how long they're going to be affected by this. You don't know what the impact is going to be like. So your main thing with the patient with MS is you want to make sure that they're safe. You want to make sure that they can do what they need to do on any given day, and you want to work towards progressing with them and making them better instead of making them worse. So that's the whole thing, where you don't want to put them into a situation where they're in a pseudo exacerbation because they got overheated or they did too many reps. So you don't want to get all gung-ho. They're doing so well today, I'm going to have them do more and more and more and more. You really, with all neuro patients, you really have to kind of take the middle road and do what you can with them that given day. And don't feel like you have to work every patient to the max, because that's going to work against the neuro patient, typically, instead of helping them. So in order to help them, you want to work at a moderate pace. And keep in mind that whole 3/5 and above and 3/5 and below, keep that in mind. So, but yeah, the patient with MS is going to make improvements, hopefully each time that you treat them. And then it could be that you come back in one day and they're doing a whole lot better, and it's just because they've gone more into a remission type state. And then you get to the point where they're not making any further progress right then, and that might be at the point that you discharge them, and it could be 6 months, 8 months down the road, you're back in there, because they're having another exacerbation. 2 weeks later, they're having another exacerbation. It's not predictable. So there's RRMS, and that's going to be 85%. Very few now go into the secondary because of the meds that are being used currently. But when you get those that are in that ongoing progressive type state, that's what you have to understand. That's what they've been diagnosed with. And these are not going to be patients that go into remission. They're going to progressively get worse. So those patients you would be doing more in terms of compensatory type activities, and you are probably going to end up discharging them before they reach their goals, because they will have plateaued at some point and they're not making further progress. And that's something ethically that you have to do. It could be that the patient's family is saying, oh, but can you keep on seeing them? If you can't document progress, and it's been a while since you've been able to document progress, after 2 or 3 times, you just need to, they have plateaued off. This is as much as you can do with them right now. So you have them on a home program, but you've got to discharge them. If they're not continuing to make progress, you have to discharge them. So that's something you need to keep in mind too. Any questions about MS? There's lots and lots of medicines, because there's lots and lots of signs and symptoms. These patients have problems with drooling. These patients have problems sometimes with swallowing. They have the bulbar type symptoms very often. Sometimes their speech is affected and it sounds very slurred. Stephen was laughing that day, but there is that video on YouTube if you wanted to look at it. She's like about 24 years old, and every reference that she has to do with drinking. She says, I think I do. And I thought, she's kind of right, that, the way you talk and your thinking and your gait, and with difficulties with balance, like a more ataxic gait. And I thought, it really does make sense. And I thought, well, really, should I show this to the students? But it might be something that you want to take a look at, because those signs and symptoms, it kind of does correlate there. But anything that you find on YouTube, now you do have to kind of take some things on YouTube with a grain of salt, but a lot of times patients will do a video online, and it really can, like that patient with ALS the other day, it really can kind of give you a visual on what's going on with these patients and what they have to go through. So CVA is another thing on the list, and I think we spent probably the most time on CVA.